I've been a surgeon for 22 years, and there are 5 surgeries, common ones, that I would never ever recommend for anyone over 65, not because surgery is bad, but because I've watched these specific procedures quietly kill people who had no idea they were in danger. Stay with me, because one of these might already be on your calendar. I'm Dr. Samuel. I've walked into operating rooms before sunrise and left long after sunset for over 2 decades. I've seen surgery perform miracles, but I've also seen what happens when the wrong surgery meets the wrong body at the wrong moment. Today, I'm going to tell you what most surgeons won't say out loud. Before the list, I need you to understand one thing that will change how you think about your body forever. Your body is a battery, thoroughly charged. Surgery is a hard day. At 6.5 bucks, that battery might be at 6% for everyday life. Perfect. You feel great, you travel. You're healthy. But surgery isn't a daily draw. It's like plugging an industrial appliance into a household outlet. One wrong procedure under the wrong conditions can take that 60% straight to zero. And here's the most dangerous secret in medicine. It's almost never the planned surgery that kills. It's the emergency. A planned surgery is landing a plane on a clear day with a full tank. An emergency surgery is landing in a storm, in total darkness, with no fuel, on a runway nobody's checked for seniors. Emergency abdominal surgery carries mortality rates of 25% or higher. That's 1 in 4 people. Those are not small odds. Here are the 5 surgeries most likely to put you in that emergency room, and exactly how to make sure they never do. HASYRY1, emergency colectomy. Number 1, the emergency colectomy. Removal of your large intestine in a crisis. This usually starts with something small. A change in bathroom habits. A dull ache you blamed on dinner. You filed it away, assumed it would pass. But it didn't pass, it festered. Until a pouch in your intestine ruptures, flooding your abdomen with bacteria. That's called peritonitis. By the time you hit the ER, you're in septic shock. Mortality in seniors, over 25%. What saves you? A colonoscopy. That's it. A sedated 45-minute outpatient procedure that removes polyps before they become a catastrophe. If you've been postponing yours, that delay is not harmless. It is a gamble with your life. Also, 30 minutes of walking daily, high-fiber diet, and never normalize blood in your stool or persistent abdominal pain are ER or fetuf, perforated ulcer. Number 2 might shock you because the cause is probably sitting in your medicine cabinet right now. The emergency perforated ulcer repair, and the culprit, ibuprofen, naproxen, the little orange or blue bottle you've trusted for 15 years. Here's what no one tells you: NSAIDs strip the protective lining of your stomach. Over time, your own acid starts eating through tissue. Most ulcers are caught and treated with a simple pill. But if you miss it, the ulcer punches through your stomach wall. Acid floods your abdomen. The pain is described as sudden, absolute, and terrifying. Mortality 15 to 25%. One question that could save your life: the next time you see your doctor, ask, since I take anti-inflammatories regularly, should I also be taking a stomach protector? That's it. 1 sentence. 1 in 4 survival odds shifted in your favor. A HASYRY faint 3. Emergency small intestine removal. Number 3. You feel nauseated, a little crampy. You figure you ate something bad. You rest, drink water, wait. If you're 30, that's usually fine. If you're over 65, especially with a history of heart issues like AFib, that stomach ache could be your intestine losing blood supply. And the window to act is brutally short. Catch it in 6 hours. IV treatment, full recovery. Catch it in 48 hours. Permanent removal of a large portion of your intestine. Some patients spend the rest of their lives on intravenous nutrition. The rule that can save you: if you have new unexplained abdominal pain and vomiting that doesn't improve within a few hours, get a CT scan. It takes minutes. It can save everything. RJY54, delayed appendix or gallbladder. Number 4 is the one that surprises people most because it sounds so routine. Appendicitis in a young person is obvious. Screaming pain, lower right side ER in hours, home the next day. In seniors, the nervous system lies to you. The pain reports as a 4 out of 10 when the biological reality is a 7 out of 10. So you wait, you normalize. By the time you reach the hospital, the appendix has often already perforated. What was a 60-minute laparoscopic procedure is now major open surgery with drainage tubes, weeks of recovery, and mortality that jumps from under 1% to as high as 10%. The lesson: new pain that persists beyond a day is not just aging. Act earlier. Every time Hesu RGR 5, hip and lung arriving unprepared, and number 5 is different. This isn't a surgery you choose to avoid, because you can't ignore a broken hip or a lung tumor. The danger here isn't the surgery, it's how you arrive at it. 1-year mortality after a hip fracture in seniors runs 17 to 25%, not from the fracture, from the shock of revealing that your body's reserves were already depleted before you fell. Most people get a surgery date 6 weeks out and just wait. They don't prepare. They arrive in whatever biological condition they happen to be in. That is a massive, preventable mistake. The answer is prehabilitation. Think of it as a training camp for your surgery. 3 things: targeted strength training, especially legs and core, starting now. Protein. Most seniors are in deficit, and protein is what heals incisions, reduce anxiety. Elevated cortisol actively impairs healing. This is documented biology, not motivation talk. And to prevent the fall that causes the hip fracture in the first place, 800 to 1,000 IU of vitamin D daily. Balance training, starting this week. Hatsilas. The surgeon's truth? Here's what every single one of these 5 surgeries has in common. None of them are failures of surgical skill. None of them are bad luck. They are all manageable problems that were allowed to become catastrophes. The colonoscopy you've been postponing. The question about ibuprofen you haven't asked your doctor. The vague symptom you've been dismissing for months. The prehab nobody told you about when they handed you a surgery date. These are not small things. These are the decisions that determine whether your story ends in a full recovery or becomes a statistic in a medical journal. You have more control over this than anyone has ever told you. If this reached someone you love, share it with them. Have this conversation before the emergency lights are flashing. I'm Dr. Samuel. Take care of yourself. I'll see you in the next video.